Hello and welcome to Unstressed. My name is Dr. Ron Ehrlich. Well, 2020, what a year. And interestingly, almost ironically, 2020 is a term that is often used to describe clear vision. And I have said during this year that it's an opportunity for us to reflect on a whole lot of things. So it's perhaps appropriate today that my guest is an ophthalmologist, but not just any ophthalmologist. My guest is Dr. James Muecke. James is an ophthalmic surgeon, an ophthalmologist from Adelaide, South Australia, and he has also been recognised for his work globally, particularly in Southeast Asia, and has been awarded the Australian of the Year for 2020. Now, this discussion is terrific. I had the opportunity of talking to James earlier in the week and just felt that there was just so much to learn from this discussion about social entrepreneurship, what that actually means. He talks about the nutritional guidelines and the impact that has had because he's chosen to champion in this year diabetes and specifically sugars and carbohydrates. And that journey has been an interesting one because as a clinician of many years' experience, his knowledge of nutrition, which he admits himself, was not terrific, and he had accepted, like the vast majority of well-meaning health practitioners or medical practitioners in particular who look at our Australian healthy eating guidelines and say, well, if they're government endorsed, then they must be right. And it's been a revelation for James, and he shares that with us in this podcast. In fact, he uses the words awareness, accountability, and action to describe what nutritional guidelines really should be like, and he also comments on how they are very much left wanting in that respect. Look, it was just a terrific conversation. I so enjoyed talking to him. He is such an inspiring and articulate person. I hope you enjoyed this conversation I had with Dr. James Muecke. Welcome to the show, James.
Thank you, Ron. Great to be back.
James, I have not covered this issue of sight, and it's a big omission on my part, but this was such a great opportunity to do just that, and there are so many other things we wanted to cover. I wondered if before we lobbed into all of your work prior to being receiving this great honour of Australian of the Year and what you've done since, I wondered if we might talk about ophthalmology, because I think that's often confused with optometry, obviously considering the same thing. Tell us a bit about your own journey, what an ophthalmologist is and how you've reached this point.
Sure. Also confused with opticians, ocularists, orthoptists.
Right, okay.
There's a bunch of them.
Yeah.
So I'm an ophthalmologist. So I'm actually a medical doctor. I trained, I had 6 years of medical school and several years of training following medical school to become a doctor, a specialist. My training involved 5 years of training to become an eye surgeon. So basically, if you compare the two, ophthalmology is a medical specialty which involves surgery and the ability to prescribe medicines and treatments to patients with eye diseases. Optometry is also a degree, but it doesn't involve surgery and very limited use of medicines that they can apply in the management of eye diseases. But optometrists play a very important role, particularly in detecting eye disease and then referring to ophthalmologists to manage many of those eye diseases.
And when we talk about eye disease, and I know so much of you've done a lot of work obviously in Australia, but you've taken this overseas into developing countries. How do the challenges that we face from our sight vary from here in Australia to, say, a developing country like the work you've done in Myanmar?
Sure. So Sight for All is the organisation that I co-founded back in 2007. And so we have projects now in 9 countries in Asia, 2 in Africa, and also here in mainstream and Aboriginal communities. And there are quite significant differences between the spectrum of diseases that we see in poorer countries versus high-income countries, not so much in the diseases themselves. I mean, there are quite literally hundreds of eye diseases. Many of these are blinding, and some are actually deadly and disfiguring. In poorer countries, the leading cause of blindness is cataract. In somewhere like Australia, in a high-income country, cataract some years ago, some decades ago, used to be the leading cause of blindness, but it is no longer the leading cause of blindness. We now have a number of diseases in elderly people. Age-related macular degeneration is the leading cause of blindness. In working-age adults, diabetes is now the leading cause of blindness. And in children, the main disease, the main spectrum of diseases are inherited or genetic diseases in kids. Now, if we look at poorer countries, I mentioned before that cataract's the leading cause of blindness. Actually, cataract is the leading cause of blindness worldwide. It makes up about 50% of cases. But in poorer countries, roughly 90% of cases are due to cataract, I believe. So we would say that in worldwide, roughly 80% of all blindness is avoidable. By that, I mean it's preventable or treatable. So 80% worldwide.
Yeah.
And in poorer countries, in children, for example, the spectrum of diseases are quite different to the diseases that we see here in Australia or other high-income countries. Now, I was involved in a childhood blindness study in Myanmar back in 2007. And this was an incredibly confronting and a very, very powerful moment in my medical career. Having never been involved in a childhood blindness study before, I wasn't quite sure what I was going to discover during that. I actually led that team, and we visited 7 schools for the blind across Myanmar. Now, Myanmar at the time was, I think, rated second only to Liberia as the poorest country in the world in terms of health expenditure. So we were expecting to be confronted by what we found, but little did we realise the experience was going to have a very, very deep and powerful impact on all of us. So through that couple of weeks of the study, we found that nearly half of the kids had blindness that could have been prevented or treated. But what was particularly confronting and extraordinary was the lead cause of blindness that we found, and that was measles.
Wow. Okay.
Now, through my ophthalmic training, I had probably read somewhere that measles could cause blindness, but I'd never experienced it in Australia and certainly never seen what it looks like. But to be surrounded by children in 7 schools for the blind, and subsequently in 2 other countries where we undertook childhood blindness studies, so in Cambodia in 2008 and Laos in 2013. Now, the way measles blinds, it actually causes inflammation, infection in the cornea, which is the front window of the eyes, and you get massive inflammation in the front section of the eye, and then the pressure control system in the eye becomes blocked. The eye then starts to expand with secondary glaucoma, and in some instances can actually rupture. So the sort of children that we're seeing, it's hard to even truly describe it, but some children had grossly expanded eyes, and others had grossly scarred eyes that had actually ruptured, essentially had popped.
Wow.
So it's a terribly disfiguring disease. The pain that these children must have experienced would have been excruciating. But when they were admitted to the schools for the blind, they were in the order of the age of 5, whereas the infection most likely happened some years earlier in their lives. So they'd passed the active, infectious, painful stage, and really we were just seeing the end stage of that irreversibly blinded condition. And what was, that was confronting enough as it was, and literally to be surrounded by a sea of children that looked like this little boy. But then to realise that it's a highly preventable disease, costs less than $1 to prevent measles in a child. So you can imagine that was, for me, a phenomenally powerful experience. And what I realised at the time, in fact, we returned to Australia, I wrote the paper up and we published it in a peer-reviewed journal. And then I went back to Myanmar to meet with the health minister to say, we've got a problem here, we need to do something about this. So I was able to to persuade him to train a children's eye specialist for the country, what we call a pediatric ophthalmologist. There was not one specialised pediatric ophthalmologist in the country of over 50 million people at the time. So in 2010, we brought a young eye specialist out to Australia, to Adelaide, to train at the Women's and Children's Hospital with myself and my colleagues, to train to be a pediatric ophthalmologist. And he returned home at the end of his hands-on year of training. It's the very first in his country. And we actually set him up in the country's first children's eye unit in the capital city at the major teaching institution, Yangon Eye Hospital, where he works to this day. And he actually now provides close to 30,000 treatments every single year, which in itself is quite extraordinary, almost hard to believe. But as his competence and his confidence improved, he started training his own colleagues. In 2015, finished training the second pediatric ophthalmologist for the country, and now trains at least 2 every single year. So it's just one example of the work that we do with Sight for All, showing its scalability, its sustainability. Now, we've trained pediatric ophthalmologists now from 9 countries across Asia, but our specialty has 9 different subspecialty areas. And so pediatric ophthalmology is just one of those. And we have been training and equipping colleagues across Asia in all of these subspecialty areas. And the work that we're doing is now impacting over about 1 million people every year. So it's really powerful. So it just gives you an example of the spectrum of diseases that we see, and also how we're dealing with those problems. Now, the situation in poorer countries, why is it so dire? Often the resourcing is not there, so they don't have quite simply, they don't have the number of eye specialists, whether they be ophthalmologists, whether they be optometrists, or even eye care nurses. They just don't have the numbers out there, particularly in regional parts of the country, to be able to deal with these diseases. And the other thing is, so there's an accessibility factor. The other is the affordability factor. And quite often in many poorer parts of the world, healthcare is not free. So here in Australia, we have free healthcare. We have ready accessibility to eye specialists, even in the most remote communities, even in the most remote Aboriginal communities. We have optometrists and ophthalmologists that visit at least twice a year. So it's those are the major comparisons between the two. Here in Australia, it's more about educating the public, raising awareness about some of the critical blinding diseases, such as what I mentioned before, diabetes being the leading cause of blindness amongst working age adults.
Yes, and we're going to come back to that. It's interesting. I mean, none of us should be surprised that so much of this is preventable, because so many of the diseases we face, per se, in the world are preventable. So the eye diseases shouldn't be any less. Interesting to hear measles being such a big problem overseas, and yet so little of an issue here. And dare I mention the word vaccination, because that's probably one of the reasons why we don't have this problem.
Exactly. And I would challenge any anti-vaxxer to spend a day in a school for the blind in Myanmar and see the impact of avoiding vaccination on a child, and the devastating effect that has on the child's life, their opportunity to have a fruitful career and a satisfying life, but also impacting broadly on the family, on the community. Actually, if we look at the number of years that a child has to live with their blindness, it comes second only to cataract as the leading cause of blindness in the world. So it's a major problem, and it's also a big driver of poverty in many parts of the world.
And cataract is another one, because, that has been totally revolutionised, hasn't it? I remember 30 or 40 years ago when my own grandparents had cataracts done. They were in hospital for a week, wore glasses for 2 weeks. It was a whole long, drawn-out procedure, and now it's a day procedure, isn't it? I mean, that cataract surgery is almost so routine now and so quick.
It is. It's still a highly sophisticated operation, highly technical, but it is been fine-tuned with the help of incredible technology. So these days, the operation itself would take 15 minutes, give or take, done under local anaesthesia, and in many cases done just simply with a local anaesthetic eye drop. And it is day surgery, and it's very, very low risk. And it's an incredibly, within 24 hours when their pad's taken off, the improvement in sight is palpable immediately. And sight is our most precious sense.
Absolutely, yes.
We don't often see, sorry to interrupt, Ron, we don't often see here in Australia patients have a much greater demand on their vision than they often do in poorer parts of the world. So we are removing cataracts at an earlier and earlier stage. But in poorer parts of the world, people are quite literally blind. In fact, I was a couple of years before, I mentioned that study in Myanmar in 2007, a couple of years before in 2005, we undertook an adult blindness study in a regional part of the country where we found that, yes, cataract was the leading cause of blindness. That was not a surprise. What was a surprise was the prevalence of cataract blindness. So close to 10% of the adults over the age of 40 were actually blind.
Wow.
But close to 1 in 10 people were actually blind, and the vast majority of those were cataracts. And even the ones that had had cataract surgery, many of them were also blind because they didn't have the equipment to be able to do the operation at the highest level. When we remove a cataract, so cataract is the clouding of the lens inside the eye. When we remove the cataract, we have to replace that lens with a plastic lens. And in many poorer parts of the world, and particularly in remote and regional parts of those countries, either a lens is not replaced inside the eye, or they put a standard lens power in, or they put an inappropriate lens power in, and the patients are often no better off than when they had the procedure. Maybe better off not having had the procedure. And one of the other things which also staggered me, and I was in my early 40s at the time, there was people, adults, who are younger than me who are blind from cataract, something that we do not see here. So there's something else going on. All of us will develop a cataract if we live long enough. It's called senile cataract. It's just part of the aging process. But we were seeing cataract in people, blinding cataract in people who are in their 40s.
So that was one of the things I was going to ask, and that is having a cataract inevitable? And is that just part of our aging process? Clearly it is. Do things predispose us, they must, to that developing earlier? What are some of the predisposing things?
There are many, many causes of cataract. There's the list that long, but the commonest cause is senile cataract. It's just simply the aging process in the eye. But a number of other causes of cataract. I mentioned before measles, so inflammation in the eye, either acute or chronic inflammation, but particularly chronic inflammation can cause cataract. There are hereditary causes of cataract, which can give rise to cataract in babies and in children, so what we call congenital cataract, and there are a number of causes of these. Infectious diseases, I mentioned measles, but also rubella and a number of other infections can cause it. Sometimes treatments, so steroids, so prednisolone, people who are on chronic prednisolone treatment or steroid drops can also develop cataract. Trauma to the eye can happen from blunt or penetrating injuries and cause cataract, and the list goes on. So many.
And macular degeneration is another one you've touched, you mentioned. Tell us a little bit about, give us 101 macular degeneration, because I've heard there are, some predisposing factors there, but talk to us a little about macular degeneration, because that's another one.
So macular degeneration is the leading cause of blindness in adults, and particularly in elderly in Australia now. And this is a degenerative process which involves the macula, which is the central vision area of the retina. And it's called age-related because as we age, this is a condition that we see more prevalent in older people, people who are in their 70s and beyond. Sometimes we see it in people in their 50s and 60s. But there is a combination of genetic elements, and it's probably quite a complex genetic process with a number of genes potentially involved, and probably also some environmental factors beyond just simply aging. Now, we don't know exactly what those environmental factors are. There are a number of theories, and diet, and particularly a diet high in sugar and highly processed foods may be a driver of this as well. But I also wonder myself, if we look back, if we turn the clock back 100 years, where many people didn't have artificial lighting, they often, when it became dark at night time. They either went to bed or just functioned with candlelight. So the illumination was a lot less. Yes, and they certainly didn't have the TV to sit in front of for hours in the evenings. These days, with artificial lighting, our day is extended probably at least 50% more than we would otherwise have done. And we also have the opportunity to watch the TV, quite literally for some people for many hours. And the TV is highly, it's bright, it's colourful, constantly moving and constantly stimulating the macula, processing the information that's coming to it. And so my feeling about this is that the macula these days, 100 years later, or maybe even 50 years later in many parts of the world, is functioning probably 50% more than it might have done some time ago. And maybe we're just simply wearing our macula out.
Interesting, because we've done various programs on breath. And, there is an approach to breath which says we only have a certain number of breaths in our life, and we shouldn't breathe too quickly because we're going to use them up. So breathe slower, be more calm, engage the parasympathetic nervous system more. And here you are saying, well, we've maybe given a certain amount of hours to be seeing life, and here we are brightening it up and using it all up perhaps far too quickly.
It's possible. It's just my own personal theory.
I like
but
it.
I think with the breaths, it's not so much that we have a limited number of breaths. It's, I think, the calming effect and minimizing the stress. And I know your podcast series is called Unstressed, and we'll get into that. But I think just simply, being mindful, calming that breath down, cooling the head down is a big driver of a much healthier approach.
And it's also a very timely reminder about, you mentioning that chronic inflammation is such a driver in so many of these degenerative diseases, which in your case, you see the manifestation of it in the eye. I mean, it's a reminder about the effect of chronic inflammation per se.
Yes, exactly. Yeah. I suspect chronic inflammation plays a huge role in many of the modern diseases that we have, and particularly the chronic diseases.
Now, the other thing was, of course, that because of this entrepreneurship, really, I mean, I know you're very passionate about social entrepreneurship, and I guess this is just a great example of it, but you go to a third developing country, let's say developing country, and you've seen something, and from the moment of seeing that to setting up a whole program is quite a big step. How did you make that in the initial stage? How did you come back and go, I've got to do something about that? How did you get going on that?
Sure. Well, if we look at just the whole world of social entrepreneurship, what does that mean? What is a social entrepreneur? Yeah. Well, we all know what an entrepreneur is, right? Someone who starts a business, takes risks in order to make money. So a social entrepreneur is someone who starts a business and takes risks in order to solve a social problem. So I actually came up with my own definition of a social entrepreneur, someone who innovates for a sustainable solution to a social problem. Now, I have thought about this a bit, and I've come up with the three key ingredients, which to me are critical for social entrepreneurship. It's a spirit of adventure, a humanitarian spirit, and an entrepreneurial spirit. So probably the biggest driver of this is the humanitarian spirit. So where does the humanitarian spirit come from? Perhaps part of it is our upbringing. Perhaps part of it's genetic, the way we learn from our parents. But I suspect for many people, just life experiences which are so powerful that just instill in them a desire to want to deal with let's say, a social problem or an environmental problem that they've come across, something that's impacted them so powerfully that they want to do something about it, is often what gives rise to that humanitarian spirit. Now, myself as a doctor, and if I look back to my childhood, I always wanted to be a doctor, and I just had this inbuilt desire to want to help people. I don't know where that came from, to be honest. I don't have any answer to that. But it has been the experiences that I've had through my life that added to that, which have been a big driver of the way my career has unfolded. And I mentioned two of those to you, that adult blindness study in Myanmar and the childhood blindness study in Myanmar in 2007, which was so powerful, so formative. When you experience something like that, you really want to do something about it. So that's when the third key ingredient has to kick in, which is the entrepreneurial spirit. Now, I mentioned also spirit of adventure. And I think, quite simply, if you love traveling and you love traveling in poor parts of the world, just simply that experience is an adventure in itself. But I think if you want to tackle social issues or environmental issues in poor part of the world, you just simply have to have a spirit of adventure, because, it's quite often a challenge. But if we take the fact that you have a spirit of adventure and you have had these incredible experiences and then want to do something about it, well, this is when you have to draw on your entrepreneurial spirit. Now, myself, I never saw myself as an entrepreneur, and I never saw myself as a social entrepreneur. And when I had that experience in Myanmar, it wasn't a difficult decision to know what to do about it. I just realized that we needed to train a children's eye specialist for that country. It was a reasonably straightforward thing to do. So the entrepreneurial spirit, to me, there are a number of key ingredients to that. And so the 6 key ingredients that I've come up with, and you could probably think of a few more, that a social entrepreneur needs to be a creator. They need to be a communicator. They need to be an innovator, a leader, a problem solver, and a risk taker. So those are just several of the ingredients that's needed to have an entrepreneurial spirit. And many of those one can learn. And I think for myself, it was easy enough to say, okay, we need to train a children's eye specialist. And so I organised that. And there was a bit of logistics involved in order to bring a doctor to Australia to train. But then to have all the mechanisms around that, which ultimately was one of the driving forces for me to set up Sight for All in 2008. So I had that experience in 2007. I set up Sight for All in 2008, and we brought the doctor out here at the end of 2009, 2010. So you have to raise money. So you have to rely on donations from the public. And in Australia, we need to be registered as a charity so that you can give tax deductions. And so in order to set up a charitable organisation, and particularly a charitable organisation that actually takes that Australian money overseas, we need to be registered with what's called the Overseas Aid Gift Deduction Scheme, part of the Department of Foreign Affairs and Trade. And now to do that, you actually have to have a registered organisation. You actually have to have a board, a constitution. So you can see you have to build all of these, the infrastructure around this process. You can't quite simply just bring a doctor to Australia to train and that's that. You actually have to set up a whole structure around it. So the first thing is the, I mentioned before in those ingredients, you have to be a creator. So you actually have to create this vehicle, this entity, which is going to solve the social problem that you've seen. The second thing is then you need to be a communicator. So I had to actually communicate that passion that I experienced by being involved in that childhood blindness study in Myanmar, to get people on board, to persuade people that this was something that we needed to address, to get a board together, to get donors to sponsor. So you actually have to be a communicator, and then you have to be a leader. If you're going to actually create the vehicle, create the entity, and start to persuade people to jump on board in your quest to hopefully change the world, then you need to lead that organisation, and then you have to innovate. And so part of that innovation was bringing the doctor to Australia to train. We also found that there are a number of countries where we couldn't bring doctors to Australia. I mentioned before that Cambodia and Laos, we also had similar results where we found nearly half of the kids had blindness that could have been prevented or treated. And in both of those countries, measles was also a leading cause of blindness. But we couldn't bring doctors to Australia to train. So we actually innovated, we problem solved and created what we call our reverse fellowship program, where we actually took the training to our colleagues, working together with them in their own centres, in their own countries, and dealing with the challenges that they face every single day. And, the final thing I mentioned was being a risk taker. So, initially, when you set up a social impact organisation or a charitable organisation, a not-for-profit, you often start off with this voluntary model, and then you have to progress to a model which incorporates paid staff, and we have a small staff team. We have 4 on our staff team, 3 full-time equivalents based here in Adelaide. So, and that in itself entails risk. So you can see how all of these ingredients slowly build to create the platform to be able to solve the social problem. And it's all-consuming. It's a huge investment of time. I used to call it my second full-time career. I used to spend 30 to 40 hours a week,
Wow.
as many hours as I was in my clinical job. So it becomes quite a consuming thing. And my wife, from the beginning, was involved. She's been actively involved in marketing and fundraising and running all of our events. But my children have also been involved. We've lived this for the last 20 to 30 years. So it becomes a really important and powerful and special part of your life. And after my family, it was the most beautiful thing I've ever been involved in. And at the end of my life, I'll look back and I'll say, yes, this has been a life well lived.
Which, 2 words that come to my mind as I hear you speak, James, is articulate and inspire. And you clearly have done that very well. And that has led you to this great honour of firstly, South Australian of the Year, which then led to Australian of the Year. And you've chosen to highlight this year in a particular way. And those 2 words, articulate and inspire, seem an appropriate segue into this. Tell us about what your focus has been on in this year and why.
Sure. So it actually, again, like many of these things, it's an evolution, and it's experiences I mentioned before about powerful experiences, which can actually, change the course of your life or fill you with passion to want to do something about it. And as an ophthalmologist, I was seeing for over 30 years now, I've been dealing with the end-stage consequences of the blinding complications of diabetes, in particular type 2 diabetes, which makes up about 90% of cases. But in all of those years, never thought too deeply about the underlying cause of type 2 diabetes, which is our poor diet, diet full of sugar, refined carbohydrates and highly processed foods, and felt that was the responsibility of the first-line health practitioners, the GPs, the dietitians and nutritionists. So I didn't involve myself in that. And then in 2018, and in fact, he wasn't a patient of mine. He was the man, his name is Neil Hansel, and I met him in 2018. I was wanting to put together a documentary, or I did put together a documentary about the experience of blindness, what it means to be blind. And so I interviewed 10 people with my son, who's a filmmaker, and 4 children who are born blind, 4 elderly people who are slowly going blind at the end of their lives, and 2 people who had suddenly gone blind in the middle of their life, just to get the spectrum of experiences and how that impacted on them in their life and how they viewed the world. But the 2 that were so powerful were the 2 that had suddenly gone blind in the middle of their life. You can imagine.
Yes.
And both actually had diabetes. One was a young, high-flying corporate girl in her 30s who'd neglected her disease, wasn't having her eye checked, and bingo, she lost vision in both eyes and is now blind in both eyes. Wow. And the other was a man with type 2 diabetes who, again, had neglected his disease. He was from a poorer family. The other one was as I mentioned, corporate girl, so money wasn't an issue here. But in Neil's case, his priority was his family and raising money to support his family in their life. And like, unfortunately, many men had neglected his own health, wasn't having his eye checks for his diabetes, went to bed one evening at the age of 50 with normal sight, and woke up the next morning blind in both eyes and still blind to this day. And so his story was just heart-wrenching, and I interviewed him for about an hour and a half, and by the end, I was in tears. My son, who is the filmmaker, was in tears. The sound engineer was in tears. Neil was in tears. It was just a harrowing story, such a powerful story that it made me really rethink this whole space. Mm. And if I could just wind the clock back just a little bit. Now, in my internship, this was my first year of practicing real medicine, and I was mainly just dealing with patients who had chronic diseases, often self-inflicted diseases, and certainly back then smoking was the big driver, but we were starting to see the dietary diseases, particularly diabetes, starting to emerge in the 80s. And I was becoming disillusioned. You know, it's not my personality. I like to be able to solve problems, and I just wanted to change, and that's why I went off to Kenya to work as a voluntary doctor for a year. And this was really life-changing for me, because now for the first time I was seeing patients who had diseases that weren't self-inflicted. In fact, I don't think I saw a single self-inflicted disease. These were mainly infectious diseases, malaria, TB, etc. Patients got better. You were able to cure patients, and that really suited my personality. As I mentioned, I love a project. I love completing a project. And I think this is also why I love the idea of ophthalmology, and particularly cataract blindness being such a major blinding problem in the world, and being able to solve that with a 15-minute operation. It really, you know, it was.
Wouldn't it be nice if everything was like that?
I know, but then and then having that experience in Myanmar, particularly with the childhood blindness and the measles, which is a highly preventable disease, really made me rethink my whole, I suppose, modus operandi. For the first time, it drove home how powerful prevention is in medicine. And one of the other things that I've now been involved in 6 childhood blindness studies around Asia, and in each of the schools for the blind that we've visited, we do also see children who are visually impaired, even blind, because they've never been tested for spectacles. Because there was no one available in that country or in that region to be able to fit them with a pair of spectacles, a basic service that we just take for granted here in Australia. But
well, look at you and I. Look at you and I. With our glasses on, we haven't even, don't even think about that.
That's right. And in those parts, in many poor parts of the world, and particularly in regional parts of the world, I mentioned before that optometrists play a critical role. And in many countries, there is no optometry service available to assess, to screen, to detect eye diseases and to prescribe glasses. And so, again, a highly preventable problem. And so when I then was having this confronting experience with Neil Hansel, and just every year seeing more and more patients losing vision and going blind due to their diabetes, I just felt that there was a real need to do something here in Australia to raise awareness. I mentioned before that, we have free healthcare. That's no excuse. We have eye specialists everywhere. That's no excuse. So why, well over half of the 1.7 million people in this country who have diabetes, why is this happening? Why is it the leading cause of blindness in working age adults? It's because, well over half are not having their regular eye checks. So why are they not having their regular eye checks? Well, there's a whole bunch of reasons there, and I mentioned 2 before. One was a very busy, high-flying corporate lady, and the other was channeling his priorities and his money into the health of his family and the education of his family and the feeding of his family. And there are other reasons I'm sure you can think of, but it then made me really think deeply about this whole process. And Neil's story is very interesting, actually. He was diagnosed with type 2 diabetes. And by the way, he doesn't mind me talking about this. He's been a big advocate. And in fact, he came onto the stage when I received my award at the Australia Day weekend in Canberra in January. But he, at the age of 16, when he left school and started earning money for the first time, he had a very busy job. And he was on the move all the time. And he was consuming 4 litres of Coke a day.
Oh my God. Wow. That's a lot of sugar. That's a lot of sugar.
That's a phenomenal amount of sugar. Now, I haven't done the calculations on it, But the major toxic component of the sugar additive in soft drinks is the fructose component, which makes up 50%. And fructose is highly toxic to the liver. In fact, it's not recognized as a food by the body. 100% of it's actually taken up by the liver, and about a third of it is converted immediately to fat. So it's a really, really toxic problem and a big driver of insulin resistance and a fatty liver, which is a big driver of type 2 diabetes. Anyway, so Neil was consuming about 4 litres of Coke a day. He was on the go, he was thin, he was fit, he was active. So we can't use weight gain as an excuse here. He was diagnosed with type 2 diabetes 10 years later. Now, in children, so he was 16, in children with excessive sugar intake, type 2 diabetes can actually develop within a 2-year period. On average, it takes about 13 years. So 13 years, Neil developed type 2 diabetes in a 10-year period. He didn't realize that he was addicted to sugar. So he was highly addicted to that. The other thing he didn't realize when he developed type 2 diabetes was the horrendous array of complications that were potentially going to confront him in his life, and which actually have confronted him in his life. So I mentioned that at the age of 50, he went blind in both eyes suddenly. And he tells this story, which we've actually made into a TV commercial, where the last thing he saw before he went to sleep was his wife's beautiful face. And it's really heart-wrenching. And but he's also had now 9 amputations. In March this year, he lost his left leg due to gangrene from his type 2 diabetes. So gangrene, loss of limb, is the second most feared complication of this disease after loss of eyesight. So he's had 9 amputations, and he's also, since he's lost his vision, had 2 heart attacks. So this is also a deadly disease. Ultimately, about 80% of patients with type 2 will die of a thrombotic complication, such as heart attack or stroke. And there are a number of other life-changing, life-threatening complications. 70% will ultimately develop dementia. Now, I lost a father to dementia, and
yes. Me too.
It's shocking. It is shocking. So this is a disease that impacts on the entire family.
Yeah. Wow. I mean, I have seen that the interview that Neil gave, and in the description of what happened, and to go to bed one night and take for granted you're seeing the world, and to literally wake up the next morning blind is so shocking, and must be so confronting. And good on him for being so open and sharing about that. But it's interesting too, James, that this was something that you've come to. I mean, you've been a medical practitioner, a specialist at the cutting edge, literally at the cutting edge for many years, and you'd left this to the dietitians and nutritionists. This was not something that. What are some of the revelations that you've come to professionally, personally, about some of the advice we've received over the years that may have led us all into this mess we find ourselves in now?
Yes, what I call our dietary disaster. So, so it's a long story. How long have we got?
Well, James, this is an important one, because I think your experience is so common to so many well-meaning medical practitioners that this deserves attention.
It does. It really does. Absolutely. And that's why I've been so public in my discussion about this during the year, using my powerful platform as Australian of the Year for 2020 to raise awareness about this critical thing. You know, if we say now that about 15%, have either pre-diabetes or type 2 diabetes in Australia, this is a serious thing. About 3.7 million people with pre-diabetes or type 2 diabetes. But there are some parts of Australia, lower socioeconomic areas, such as Greater Western Sydney, where 50% have pre-diabetes or type 2 diabetes. We're now seeing this disease in children. You know, as children as young as 7, we're seeing it here in Australia. This was a disease that used to be called maturity onset diabetes, and it's been devastating Aboriginal people as well. So it's this is a critical thing. And the biggest driver of this is our poor diet. In fact, our poor diet is responsible for more disease and death than inactivity, smoking, and alcohol combined. So diet is the big driver of this. And nutrition is something that I never got taught at medical school. And my son, who's in second year medical school, has just finished an elective in nutrition. He chose to do that.
Good on him.
Good on him, exactly. He's heard me rabbiting on this year, and I think he decided that he should do it. But it's not compulsory. And yet, the biggest health issues that we have in our society these days and globally is related to our poor diet. So doctors all need to have a grounding in nutrition. So it's something I think we need to advocate for sure. Now, myself, when I received the South Australian Award just over a year ago, I was at my speech, I talked about the fact that, we need to encourage people to have their eyes checked if they have diabetes. But then going forward to the National Award, I wasn't expecting to win it, but I wrote a speech thinking that if I do happen to win, then I'm going to use the platform to raise awareness of the root cause of type 2 diabetes. So I started thinking about the toxic impact of sugar in our life. And I came up with a concept that I call the 5 A's of sugar toxicity. So the first A, addiction. Sugar is highly addictive. It's been shown to be as addictive as nicotine. Second A, alleviation. We often use sugar to alleviate stress or to make us feel better when we're down. Third A is accessibility. Sugar is cheap and absolutely everywhere in our lives. You can't check out from most supermarkets and stores without being confronted, enticed by half-price soft drinks and chocolates. Addition, something like 75% of our food and drinks have added sugar. And the fifth A is advertising. Now, our world is flooded. We are bombarded constantly and with TV commercials and ads for sugary products. And when you realize this, actually, as soon as you step out the front door, you just realize how powerful sugar is in our lives. So I came up with this strategy and then a way of dealing with the 5 A's of sugar toxicity, but also 2 or perhaps even 3 overarching A's. Firstly, awareness. So being aware that sugar is highly toxic. We use it to alleviate stress. Being aware how much added sugar is contained within foodstuffs and drinks. The second overarching A, awareness. Second overarching A is accountability. I mentioned awareness already. So accountability. Accountability of businesses and of industry to do the right thing by people and by the health of our people. And also accountability of government and accountability of government to take action. So the action is the third overarching A. And to be honest, if we're talking about action and if we're talking about our diet being such a huge driver of chronic disease, we still see on TV ads discouraging us from smoking, but never on free-to-air TV have I seen any commercial raising awareness about the toxic impact of sugar, the dangers of ultra-processed foods, and the horrendous, devastating complications of type 2 diabetes. No awareness-raising strategies. So that's something I've been campaigning. I've been lobbying the government to let's actually have a broad public awareness strategy to raise awareness, not just type 2 diabetes and obesity, but also tooth decay. Sugar is the leading cause of dental caries, tooth decay in our society. Something like 40% of 10 to 12-year-olds have decay in their adult teeth. It's the leading cause of surgical admissions for children. It's the leading cause of days off school, 50,000 days lost every year to tooth decay. So, that's another story. Critical things that we need to be aware of, this is so vital. And a number of other things that I've discovered during the year. And one of the big concerns that I've had is our Australian dietary guidelines, which are well and truly outdated now. And they're flawed. They've been conflicted by heavy industry influence, but they continue to discourage the eating of natural saturated fats. And yet natural saturated fats have never been shown to be linked to cardiovascular disease. And they continue to encourage the eating of cereals and grains, which have been linked. Carbohydrates, and particularly sugars and refined carbohydrates, have been linked to cardiovascular disease. And yet, these are nutrient poor and non-essential. There's not a single biochemical process in our body that demands that we ingest sugar and refined carbohydrates. And yet, probably close to 2/3 of our diet is carbohydrate. So this dietary guideline, which is very powerful. In fact, I had a friend recently who said, I didn't even know we had dietary guidelines. I didn't know we had dietary guidelines at the beginning of this year, but they're, they're actually quite powerful. They're actually very powerful. They inform what's eaten in schools, childcare, aged care, prisons, the Defence Force, hospitals.
Well, medical practitioners like yourself who aren't particularly literate in nutrition would look to those, you talk about awareness and accountability, would look to those government-endorsed guidelines for advice, which makes it even more disturbing.
It is, and the guidelines in themselves, the advice, I believe, is flawed, but the guidelines say in the preface that the guidelines are intended for healthy people, okay? But the average Australian is not healthy. So 2/3 of adults over the age of 24 are overweight or obese, so we're metabolically not healthy. In the United States, 88% of Americans are metabolically unhealthy. And about 1/3 of our kids are also metabolically unhealthy. So the average Australian is not healthy. So those guidelines, which are intended for healthy Australians, are not appropriate. But the other thing which is concerning is that there are a number of bodies, including in the GP handbook for the management of type 2 diabetes, they recommend eating by the Australian dietary guidelines. Yes. So this is type 2 diabetes is a disease of carbohydrate intolerance. And yet the management handbook for general practitioners is recommending that people with diabetes eat by the Australian dietary guidelines. It makes no sense. Even Diabetes Australia recommends eating by the Australian dietary guidelines. So one thing I've been lobbying that the guidelines need to be changed, but also these organisations which are endorsing the guidelines need to stop endorsing the guidelines. And I'm pleased to report that through my lobbying a couple of months ago, Greg Hunt announced that the guidelines are going to be reviewed, which is great. But they need to be reviewed. We need to keep industry out of it, particularly the ultra-processed food industry out of it, with their conflicts of interest. It needs to be created in a fair and independent way, but it's going to take at least 3 years. And in the meantime, we'll probably see in the order of 50,000 people die of type 2 diabetes. We'll probably see in the order of 300,000 new cases. There's about 250 new cases of type 2 diabetes every day. So this is why awareness raising is so critical here.
And I know when we spoke the other day, James, that we were both lamenting or commenting on the fact that here was a subject we both covered in second-year undergraduate, and that was biochemistry, which had all sorts of pathways like the Krebs cycle and gluconeogenesis and oxidative phosphorylation and glycolysis. And we, probably you like me, couldn't wait to pass that exam because thank goodness I never had to worry about those pathways again. Little did I realise that I had to worry about them every single day of my life.
Yeah, exactly. And yet, as you say, you step out of that exam and the Krebs cycle gets locked away in a dark, deep recess of your memory somewhere. And in fact, I hadn't thought about the Krebs cycle until this year. So how many years later is that? Yes. But the Krebs cycle is the critical cycle here. And I mentioned before that there's not a biochemical process in our body that demands that we ingest carbs and sugar. The Krebs cycle can create all the glucose that we need for energy in our bodies from fat and protein. So it's such a critical piece of information that we need to be aware of. And one of the other things I think that I discovered this year, in fact, I was invited to be on the expert advisory group for the National Diabetes Strategy Review a few months ago. And I was reading through the strategy and I realized nowhere in that document was there mention that type 2 diabetes can be put into remission or potentially reversed. Nowhere in that document. And at our first meeting, I raised, at the very end of the meeting, because no one else had raised it, I actually said, shouldn't in this document somewhere be the very important, very critical issue that type 2 diabetes can be put into remission? And so I'm pleased to report that we now have remission in that document, so which will give GPs and health educators, health practitioners who are also informed heavily by the dietary guidelines, the comfort that they can actually now discuss the opportunity for remission with their patients. This is something I think many health practitioners have been too scared to discuss with their patients, because there are examples of health practitioners who have been reprimanded by our medical board, our overseeing medical board, for giving patients advice about their diet. Can you get that, Scientifically trained doctors have not been allowed to give dietary advice.
Well, I know I have on this podcast spoken to one such doctor, and he's an orthopedic surgeon in Tasmania, Dr. Gary Fetke, who was dealing, like you, with the ravages. So you talk about Neil's amputations. Well, it's more than likely doctors like Gary Fetke were doing that. And Gary quite correctly felt compelled to talk about what you've just talked about. And I think we've come a long way, James, to think, well, I wonder about whether you would have got the Australian of the Year if you'd started talking about this before, but it's good on you for doing it. And it's one of the reasons I wanted to talk. It's music to our ears, James, because confusing health messages are a major source of chronic disease in our country. And that conflicting of industry is a very big component of that. I think also another one I would add is the ego and reputation of practitioners who have been espousing a certain approach for their professional life to turn around and go, hey, actually, you know I've been telling you for the last 30 years saturated fat's a problem, but I think I was wrong.
Yeah.
That's a big step professionally, isn't it?
It's a huge step, and we do need to admit that at every layer, from the health practitioners and educators through to our Department of Health. It's time to say, sorry guys, we've got it wrong. And I mentioned before how powerful the guidelines were. When the demonization of natural saturated fats happened back in the 70s and 80s, quite literally thousands and thousands of low-fat products were created. Yes. And when you reduce fat in a food, you take away the flavor, you take away the ability to be satiated, filled, right? And so you need to replace that with something, and quite often that's replaced with sugar and carbohydrates. And so this has been also a big driver in processed foods of this epidemic of type 2 diabetes. So we do need to turn this around. So it does need to start at the top, and the awareness needs to reach practitioners and the public, because for so long, what we've just known is that saturated fat is bad for us, but actually it's not. It's actually critical to our survival.
Do you know, interestingly, James and I, obviously through my role at the Australasian College of Nutritional and Environmental Medicine, come into contact with many practitioners, we've been going for 40 years, who do study nutrition. And I also know many practitioners like yourself who have been working tirelessly in their own area and who have rather, with the best of intentions, accepted the nutritional guidelines on good faith. And I think the influence of industry is a story that is very easy to miss, but once you become aware of it, very difficult to ignore.
Exactly. And if we look at the guidelines, and if we look at the cereal and grain section of those guidelines, the majority of the references for that section are funded by industry.
Well, I know this is an article you shared with me before, but in a review published in the Annals of Internal Medicine in 2016, 33 of the 34 studies that were not funded by industry showed that sugar-loaded beverages cause obesity. In contrast, none of the 26 studies that were funded by industry showed an association. Nutritional science is hugely conflicted by the food and beverage industry, and I'll actually add to that the pharmaceutical industry, but that's a whole other story. So the impact of industry on research is huge and really goes a long way to blurring a clear picture forward for well-meaning health practitioners. I just wanted to take a step back now, James, as a professional and as a social entrepreneur, because we're all on this health journey together through life in this modern world. What do you think the greatest challenge is for an individual on that journey? You've covered many challenges, but what do you think the biggest challenge is for an individual on that journey in our modern world?
Do you mean in terms of their health of their diet?
Yeah, well, just in terms of their journey through life and its impact on their health. What are some of the things? What is the biggest challenge, do you feel, that might affect an individual's either health positively or negatively?
I think the biggest challenge, actually, when we go back to those 5 A's of sugar toxicity and the addictive nature of sugar. It is so incredibly powerful. And again, I mentioned I wasn't aware a year ago that sugar was addictive, and yet I was highly addicted. I've been addicted to sugar all my life. I probably still am, actually. You can see I'm tall and thin, but I found out early this year that I actually have a fatty liver. And I mentioned before that a fatty liver is a big driver of type 2 diabetes. So I'm what they call thin on the outside, fat on the inside. And we know that in the United States, and I suspect here in Australia as well, there are more thin metabolically unhealthy people than there are obese metabolically unhealthy people. So it's not obesity which is the big problem here. It's actually not even the number of calories, but it's the type of calories, and particularly the sugar that we're ingesting. And if you then look at the fact that our world, our environment is so flooded with sugar, it becomes hard to resist. I know if I've got ice cream in the house, I can't resist it. Even though I've now detoxed for the most part from sugar, it's such a powerful driver that we need to be aware of that. And once we're aware of it, then we can start to put in place those personal mechanisms to try and avoid the sugary products in our life. So it's a really important thing, and just the awareness. But I think we also need to have, this is where I say before, accountability of businesses and industry, and ultimately the government, to stop the predatory sales and marketing tactics of industry and business. So, for example, remove all of those sugary products from checkout counters so that you can go through a checkout and not be enticed, compelled to buy those 2-for-1 chocolates and then eat them before you even get home. So, this is so important, just to protect the environment of people who are addicted, and I would say that the vast majority of us are addicted to sugary products, at least have a physical dependency on it. So I think these things are very important: awareness, accountability. But also I think if we step aside from the whole sugar toxicity, type 2 diabetes issue, having a positive approach to life is really, really important. And for me, positivity is absolutely critical in building personal resilience. Is also critical in building resilience as part of a group or an organization, and even globally. We are in the midst of this COVID-19 pandemic, which is impacting on the world globally, and we need to draw on our resilience. And so a positive approach is a really important part of this. And I've come up with this concept, which I've called the 4 good things to forging a positive mind. And it helps me in my daily life. 4 good things are good health. So, when you're suddenly confronted with a life-changing moment or an adversity, you can't suddenly have good health. So eating well, avoiding sugar and those highly processed foods that I mentioned is a very important part of that for having health that allows you to deal with confronting experiences. Also, exercise is very important to building health and mental health in particular. So the second is a good sleep. When we don't sleep well, we don't deal with things so well, we're not as resilient. The third thing is good friends. Surround ourselves with people who are positive and uplifting, not people who are trying to drag you down, toxic people. And the fourth is what I call good habits. So when you're stressed, and when you're chronically stressed, like many of us have been over the last few months, the body is flooded with the stress hormone cortisol at a low level, and that's not healthy. Physically, it's not healthy, and mentally, it's not healthy for us. And there are ways of dealing with that stress, and you can actually choose bad habits, unhealthy habits. We can smoke, we can take hard drugs, we can drink too much alcohol, we can eat too much sugary food. They all trigger the release of neurotransmitters such as dopamine from the feel-good center. So they all work to make us feel better. But of course, ultimately, they're not healthy, particularly if we do it in excess. But there are other good habits, healthy habits that we can take when we're feeling stressed. So rather than reach for that block of chocolate or that 2-litre bottle or 4-litre bottle of soft drink, why not take the healthier option? Go for a walk out in nature, somewhere beautiful. Listen to your favourite music. reach out to someone else who's having a tough time, do a good deed. These have all been shown to be as effective as sugar in balancing that cortisol reaction that's flooding the body during anxious times. So I think, I'd like to leave people with the message that, forging a positive mindset allows us to get through difficult times, build our own resilience. And there's also a way of actually, forging a more positive mindset through exercise, not just physical exercise, but mental exercise. And this has actually been shown through the neuroscientific field of neuroplasticity. We can actually, the way we pay attention can actually change the brain and change the way we see and do things. And there's a very famous study that confirms this. And what I do every morning before I go to the computer or look at my smartphone, I think of 3 good things that I have to look forward to during the day. 3 things that, something that's appealing through my day. And at the end of the day, before I fall asleep, I look back at my day and say, okay, what 3 things have I experienced this day which have been wonderful, which have been positive, which I have to be grateful for? And, it's interesting. I've not had the easiest year this year. And, I saw all of my fabulous opportunities as Australian of the Year dissolve away within those early weeks of the COVID pandemic. But what I used to get out every morning or most mornings and go for a walk up in the Adelaide Hills, and that exercise was fabulous. And I'd get to the top, at the highest point, and I'd look down over the city, and often it was still dark. I'd look down over the lights of the city and think of 3 things that I had to look forward to during the day. And I must say, at a stressful time in my life, I'd never felt more positive. And when I moved into that more positive mindset, it allowed me then to think, okay, well, what am I going to do to turn this around? It allowed me to then innovate, and that innovation is also a critical part of building your resilience. And so for me, the innovation involved turning my messages online, rather than speaking at live engagements, conferences, dinners, etc. I then started creating keynotes, which I then delivered through these various internet platforms. And so ultimately the message has perhaps reached an even broader audience than I might have otherwise done. So I think these things, keeping a cool head, being positive and using innovation allows you to be resilient in your life.
Well, I think the 2 words that come to mind as I hear you, James, is articulate and inspiring. And again, congratulations on not only your amazing work as a social entrepreneur, but also in this year, which you have reached a very broad audience as Australian of the Year for 2020. We'll have links to your site, of course, but thank you so much for joining us today and sharing your wisdom and insights.
Ron, it was wonderful to be with you this morning. I really enjoyed it, and I wish you all the best for Christmas and for 2021. Here's to the world opening up next year.
Thank you. I had the honour of speaking to James on just a few days ago for the Australasian College of Nutritional and Environmental Medicine. We'd invited him to do a keynote for our annual general meeting. He was unable to do that, but we recorded a short 15-minute interview for that meeting. And as I was listening to James, there was just so many points at which I wished he was a guest on my podcast, because there I can stop and ask him questions and hear much more about what he was doing. And what he has done is so incredible. I think it's so interesting to hear the Australian of the Year pick diabetes and sugar or carbohydrates, as he observes, to champion the cause, where as a specialist ophthalmic surgeon, because one of my earlier guests on this podcast was orthopedic surgeon from Tasmania, Dr. Gary Fetke, and Gary was professionally crucified for having the audacity to suggest just what James Muecke is championing, which we all know should be championed. And that's an indication of the power of industry and influence, which is a theme I cover a lot on this podcast and will be covering more of. But it's an indication of the power of industry on all levels of healthcare, not just on industry and government, but on regulatory bodies and professional organisations that would actually take an orthopaedic surgeon to task and threaten him with deregistration for having the audacity, as he is cutting off the limbs of patients who suffer from type 2 diabetes, entirely preventable, and as James has observed, reversible. And he was almost deregistered for that. It led to a whole 3 years, a nightmare. If you are brought before regulatory bodies for anybody, but as a health professional where your registration or your ability to practice can be removed, it's a nightmare. It's a nightmare that went on for Gary for 3 years, and he was eventually vindicated. And here we have James Muecke, Australian of the Year, spending 2020 championing something which he has only come to later in his professional career. So I thought it was it's a terrific story of James. I think he is an inspiring individual, and he's been recognised for that, and he's run with it beyond his work as a social entrepreneur to make a difference in Australia and globally as well. I will have links to his website. Look, the 2021 is going to be an exciting year. We are looking at doing a lot of online programs. We're going to be doing more podcasting. There's the Unstressed app, of course. Do go online and leave us a review. We want to get this message out to a much broader global community. So thank you so much for joining me today. I hope this finds you well. This is Dr. Ron Ehrlich. Until next time, be well. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.